Right. Good morning, everyone. Welcome to the Medicaid monthly virtual meeting. We will give it just a moment as folks start to come in. So just give us a second and we'll get started. Okay, looks like the wait room is empty, so we'll go ahead and get started. Good morning. My name is Veronica Judy Cecil. I'm Senior Deputy Commissioner here at the Department for Medicaid Services. We appreciate you taking time out today to join us live, or if you're watching it recorded, we know that everyone's time is very important. And so to carve out some time to be with us and to listen to our updates today, we appreciate it. We have a really full agenda. Next slide, please. As we generally do, we'll be giving our regular monthly update on Medicaid renewals. We've got an update on the 1115 community engagement waiver, on behavioral health prior authorizations, on an update. We talked about a little bit at the last meeting on recertifications in our 1915C home and community-based waiver. So we're going to give an update on that, an update on our 1915I RISE initiative. Our sister agency spotlight today is the Department for Aging and Independent Living. And so they are here to talk about one of their programs. And then our regular, our Healthy Kentucky Home update. And this month is on men's health. And so we'll be talking about men's health as part of that. So let's get started. Next slide, please. Next slide. This is probably the last month we're going to talk about this because on June 30th, 2025, we will be finally ending all of the flexibilities that we had implemented as part of the COVID-19 public health emergency. The ones that we think that are really impactful to our members are listed here. And so we want to remind folks of those changes that will start on July 1. The first that is most important to us and really what we've been talking a lot about is that we have been under a flexibility automatically extending child renewals. So when a child was up for their annual renewal, we were automatically extending them 12 months. That ends on June 30th. So starting with July renewals, children will have to go through a redetermination. The children continue to keep their renewal month. So this will start with July, but then we have children renewals in every month thereafter, and they will have to go through that redetermination. We also, a big change to our members is that when they were going through a renewal, if they had received a renewal notice, we had been giving them a 1-month extension for all members or up to 3-month extension for long-term care and 1915C waiver members if they hadn't returned their information to us by the renewal date. We were automatically doing that. That also ends on June 30th, which means that will be very important for folks to return that renewal notice by the renewal date because we will not have any authority to extend them. The last one I wanted to talk about is that we instituted the ability to do telephone signatures, and authorized representatives have been able to do that without a signed designation. That ends on June 30th. After June 30th, starting July 1, an authorized representative will have to have a signed designation on file for that member. We will put that information into the chat where you can find that form. So that will have to be on file for that authorized representative to be able to sign an application or renewal form over the telephone. This does not apply to a connector. Connectors are not authorized representatives, but just want to make sure that that's clear for folks. So let's go to the next slide. Uh, because of this, and we talk about this every month, just to try to keep it up on everybody's mind, that the most important thing for our members to do now is ensure that if they have a change in their contact information, their mailing address, a phone number, an email address, if they have any change, if they could please make sure that they have conveyed that and put that on record for their case with the state. We rely on the mail to send out notices. We also do a phone call to remind folks if they do have to go through a renewal that requires information. We do try to contact them by phone, we text them, and we email them. So we try to use every mode of communication available to reach out to folks that are going through what we call an active renewal, that they have to return something back to us for us to make that determination. So they can update information. They can create a self-service portal account on Connect, or they could call the Connect hotline, which is there. It's 855-459-6328. There are various ways in which they can update that information, and just making sure folks know they after starting July 1, we can't automatically extend them, and children are going through a redetermination. So we really need to be able to contact those members. Next slide, please. As we've talked about every month now, there's nothing really new in terms of our trend on enrollment. We're staying pretty steady around that 1.4 million, 1.45 million number. So this, as you see here, still reflects that we're right about that in terms of total enrollment for Medicaid. Next slide, please. I'm not going to go through this entire chart, but this is just an example of the information that is available through our monthly CMS, the Centers for Medicare and Medicaid Services, monthly reports. We do one by the 8th of the month for the month before, for the renewals that were in the month before, and then we do another one 90 days after the month of renewal to report any pending cases that have been processed, which is what you see here. So this really takes all those reports and puts them into this table. But the actual reports are out on our website. So if you really want to dig into a month and see a little bit more information, you can go to our website, which we'll share with you, and be able to see a little more detail at each month. But just for an example, to walk you through that bottom line for February of 2025, we had 67,936 individuals that went through a renewal. We were able to approve 59,672 of those. We did have to disenroll, terminate 1,703, and we had 3 pending cases when we came up at the end of February. We processed all 3 cases within that 90-day period that followed. And you see on the right-hand side that we have bucketed those 3 in either approval. We were able to approve 2 of those, and we did terminate or disenroll one of those of the 3 that were processed. And so we have 0 pending. But again, all this information is in more detailed reports on our website. Next slide, please. We always show the last 3 months so that folks can see the, and we do that because there's a couple of additional information on this. That is the extended population. You'll see there the column that says extended. That's that flexibility I talked about, where we can extend a person 1 month or long-term care and waiver members up to 3 months. When you think about starting July 1, we're not going to be able to do that. this is how many people are potentially impacted because we can't extend them beyond their renewal date. So again, very important for us to make sure folks are receiving communications and responding. So we'll just take May as the last month, and we just got the numbers on June. So sorry that we don't have that. I'm sorry, May is the last month. I'm sorry. We had 54,344 renewals. We had 46,409 were approved. We had 1,379 that were disenrolled or terminated. We didn't have any pending cases at the end of the month. And then we extended 6,556. And then the far right column is reinstatements. So one of our flexibilities has also been able to reinstate individuals within a 90-day period if they then came in and provided the information that we needed and determined them eligible. So we tracked those back in the past 3 months because of the 90-day period. And for May, we have already reinstated 514 individuals. Their reinstatement goes back to their date of termination as if there was no gap in their coverage. So we keep track of that as well. Next slide, please. I talk about communication, and we have a lot of information out on our website that could be utilized for folks that want to you can pull these down, you can print them off, you can share them. We do ask that folks do that. We particularly ask providers, as you have members coming in for visits and to access care, having some of these posted to remind members that we are doing annual renewals. And so this is, a great way to share. A lot of these also help people understand the process. We've really tried to distill the information down to make it easy to understand what to do if you run into a problem. And it's also great for providers and advocates and families and others that are supporting Medicaid members through a renewal, where to go if there's a question. One in particular helps members navigate having how to create that or that account on the self-service portal, and if you're running into problems. So again, we just ask that folks share this information and try to distribute it as widely as possible. Next slide. And for children, we did a special communication plan for them with the child renewal starting. We have child-specific renewal flyers and information out there, again, asking people just to please share that as much as you can. We have a toolkit. The toolkit also has a frequently asked questions to help anybody that is trying to support a child that is going through renewal. So to kind of help answer questions. And again, available, we've shared this with the Friskies in the schools, the connectors. We've shared it with advocates and community-based organizations. The toolkit is out there to be shared with anybody and everybody. So we do ask, please feel free to pull that down and share that with all your networks so we're getting the word out. We also are, for the child renewals, our connectors do attend a lot of the school events, back to school events and others. And so they will be taking this information and sharing it at back to school events as well, trying to reach folks where they are as much as possible. Next slide, please. And this is the website. So all the information we've talked about today, all of the flyers, the toolkit for the children's, the CMS monthly reports, all that information is out on our website. So please access that if you're interested in the information. Next slide, please. Okay, and now we will talk about the 1115 community engagement waiver.
Hello, my name is Leslie Hoffman. I'm Deputy Commissioner, a Deputy Commissioner in the Department for Medicaid, and I'm going to go over our new 1115 Community Engagement Waiver. In 2025, Kentucky passed House Bill 695, and that law instructed our cabinet, CHFS, to start a community engagement program. With this new program, CHFS will automatically refer certain Medicaid members to the Department of Workforce Development for job support and coaching. The Department of Workforce Development will reach out to these members to provide information about job assistance. The community engagement program will apply to individuals in Medicaid in the Medicaid expansion eligibility group who have been enrolled in Medicaid for more than 12 months, are between the ages of 19 and 60 years of age, are physically and mentally able to work as defined by our cabinet, CHFS, are not caregivers of dependent children under the age of 18, or a dependent disabled adult relative. Okay, so we have quite a few. I'm going to pull this up because my eyes are not great anymore, so I can see it. So we have several exemptions for this. CHFS will exempt Medicaid expansion eligibility group members who meet at least one exemption or following condition for an automatic referral to the Department of Workforce Development. Individuals, of course, that are under 19 and over the age of 60, individuals responsible for care of a dependent child under age 18 or a dependent disabled adult relative, individuals that are diagnosed with an SUD, substance use disorder, or an SMI, serious mental illness, a chronic disease as determined by our cabinet, CHFS, an acute medical condition, could be physical and or behavioral, that would prevent them from complying with these requirements. Individuals eligible who have been determined based on disability or who have been deemed disabled by the Social Security Administration, SSA. Individuals with verified earned income, individuals receiving unemployment insurance income benefits, pregnant women, individuals who are homeless or were recently made homeless for up to 6 months post-housing, individuals who are victims of domestic violence, individuals who have recently been directly impacted by a catastrophic event here in Kentucky, such as a natural disaster or a death of a family member who is living with them in the same household. Individuals already participating in the workforce participation program already that CHFS has determined that meets the objective of this community engagement waiver program. So a lot of the folks that are already participating in SNAP will already meet this objective. Former foster care youth up to age 26, and then other good cause exemptions as approved by CHFS. So you may ask, how are we going to determine this? How will we have the appropriate information? So we plan to develop a self-attestation for folks to let us know why they feel that they would not meet the criteria or that they should be exempted. Next slide. Okay, so the last time I did the monthly update, we have completed our federal regulation for public comment period of 30 days from May the 13th through June the 12th. We completed that. We also held a virtual public forum on May the 22nd during the MAC meeting, the Medicaid Advisory Committee. We held an in-person public forum at the Transportation Cabinet on May the 23rd, and we have accepted via email or just regular mail through June the 12th. So with that all said and done, we had 189 attendees for the two public forums, and we have received 25 comments with additional comments coming through our email. I think we have approximately 43 total comments that are unique, which means they are not duplicates of each other. Next slide. So you may ask what's coming next. We will compile, summarize, and respond to all those public comments that we received via email, via mail, and via the virtual and the in-person forum. We will compile them into categories and then make responses back to those categories. And when I say categories, that means ones that are similar or alike. So when I was talking about unique, it means unique questions different from one another, because oftentimes they're the same comment or the same question. We will incorporate the summary of public comments and the final changes all to the 1115 demonstration proposal, and then we will take all of that, including all the comments that were made and our responses to the comments. We will submit them to CMS, and then we will also post them on our website. Our plan is June 25th, and right now we are on target. I would like to say and give a big shout out to those who participated in making comments. We had members, providers, organizations, and advocacy groups that made comments on this particular waiver, and we appreciate you taking the time to do so. I always add this in because it's an 1115, and I know we use a lot of acronyms and numbers here in Medicaid. When an 1115 is approved, it's a demonstration program, and they expect us to do a lot of things for CMS before we can actually implement. So even though we get an approval or will get an approval for this, we don't start on the day of the approval. We have to develop an implementation plan for CMS, and that usually occurs after the approval. We also have to develop a monitoring plan that's after approval, an evaluation plan after approval. And then ongoing, we have to do midpoint assessments, so 6 months, and then annual reports thereafter. And then we do final evaluation reports within 18 months after the end of the demonstration. So there's a lot of things that go into 1115s that folks probably don't realize, but this is one program or the word waiver that will not be implemented on the day of its approval from the federal government. Believe that's it. Thank you for listening to me. I always enjoy sharing information. And I think Angie Parker's up next.
Hello. Good morning. I'm Angie Parker. I'm the Director of Quality and Population Health, and I'm going to talk a little bit about the behavioral health prior authorization that is just being reinstated. Next slide. So back in 2020, and I hate to go back that far, and we're still talking about COVID, but in behavioral health and medical services for prior authorization for those services were paused during COVID, and medical services were reinstated in 2022. However, behavioral health services still remained paused until now. In March, House Bill 695 was enacted during the legislative session that required reinstatement of behavioral health prior authorization within 90 days. And within 90 days from that date, that means June 25th. So back in April, a provider letter was sent notifying providers that of this change, because we had previously started looking at prior authorization as a cabinet and as a department, and how to start reinstating prior authorization. But due to the legislative session in House Bill 695, that was given back to the MCOs to incorporate behavioral health prior authorization, in which they had in place as of January 1st, 2020. There was also a letter that was sent out regarding psychoeducation and that includes peer support services. And so that part of that letter was rescinded in that letter as well, allowing the MCOs to set their own guidelines for those types of services. Due to this change and bringing this service back, we have instructed managed care organizations to provide no less than a 30-day notice, which all providers should have had this notice by now, because this does go into effect next week. And they are also out to offer training prior to and after the restart of the prior authorizations, and provide one-on-one support and other considerations for a smooth transition. We realize that this is different. It could be new for some providers who may have never had to submit prior authorization for behavioral health services. Now, we have developed a form that combines each MCOs and what their requirements are starting June 25th. And I'm going to put that link into the chat so that anyone can see that. It's on the DMS website. Next slide. Here are all the managed care organization contact numbers, which all this information will be provided after the meeting, but you can always contact the MCOs via these phone numbers if there are any questions or concerns with the reinstatement of behavioral health prior authorizations. Thank you. And next is Carmen, I believe.
That's me. Good morning, everyone. Carmen Hancock, Division Director for Long-Term Services and Supports. Like Senior Deputy Commissioner Judy Cecil mentioned earlier, we did provide you some information in a previous meeting with regard to annual reassessments with our home and community-based waiver population. DMS started to notice early in April of this year that there seemed to be an increased number of denials for HCB annual recertifications. We immediately started looking into this and trying to find some commonalities and trends and contributing factors. What we did as an exercise was to go back to the beginning of January 2025. That seems to be the time frame when the impact of the denial started to occur. So we went back to the beginning of January 2025 and pulled any reassessment denial for home and community-based services that was made to, we started with first our youth, so 18 and under. We pulled every denial and did another internal review on those denials. With regard to youth, we did conduct 151 reviews at the DMS level. Of those 151 youth, 112 cases were reinstated. They were deemed to have met level of care. Those youth have been notified that they did have an additional reassessment and that their levels of care were being reinstated. 39 of the denials DMS felt were appropriate. Those are being upheld. However, those families were also offered another opportunity to request an appeal. That was sort of the first line that we took, was looking at our youth. That seemed to be the area of most concern. Many of you all might have seen stories in the news or families sharing stories about denials, and that really was concerning to us. So we focused on our youth first, but we also wanted to make sure that we had a handle on the entire HCB waiver participant population. So next slide. We did a comprehensive review of our adults as well, who had experienced the denial decision at their recertification. That was 154 adults. This is 19 and over. Of those, 67 cases have been reinstated, and their level of care has been awarded and extended. 87 of those DMS felt that per the regulation, they did not meet for home and community-based waiver nursing facility level of care. So those denials are being upheld. Those folks are also receiving letters offering them another opportunity for an appeal. Additionally, we have instituted, at least for the time being, a second line review on any potential denial from our vendor. So currently we are in communication with that vendor daily with regard to decisions that their MDs might make if they feel a person does not meet for nursing facility level of care. They're sending those to DMS for another review before any decisions are actually made. And we are working with the vendor on those on a daily basis. I think that's it for me. Thank you.
Good morning. My name's Tanya Dickinson. I'm with the 1915I RISE program, and so glad that I had the opportunity to join you all today. We are working on implementing the 1915I RISE initiative. I want to share a little bit about that with you as we get closer to phase 1 of our go live process. Slide. A little bit about what a state plan amendment is. If you're familiar with the waiver programs like Michelle P. or SCL. The RISE initiative is going to be very comparable to that, but there are some operational differences at the Medicaid level. It allows a 1915I amendment allows states to define a target population to receive home community-based services, defines what kind of services can be included in that benefit. It targets a program to that population based on needs, and it's a statewide benefit that will be available to folks who have a serious diagnosis of serious mental illness but do not need an institutional level of care. Slide. The 1959 RISE initiative specifically, it will provide a brand new benefit under the state's Medicaid services, and it's designed for individuals with a diagnosis of serious mental illness with or without a co-occurring diagnosis of substance use disorder, and it will bring 10 essential support services to those individuals within their communities. And like I said, we're going through a phased go live process. The first phase will be July 1 as we begin working with potential providers. Slide. RISE initiative is exactly what it says it is in the acronym. We try not to talk too much in acronyms, but it takes too long to say recovery, independence, support, and engagement every time we name the program, so we do refer to it as RISE. But it is there for just that purpose, to help participants rise above the challenges that they may be experiencing as a result of their diagnosis or related things going on in the community, and to help them succeed in that community by providing those targeted services. Slide. The qualifications for the program are really pretty simple. The individual must be an adult, age 18 or older, and enrolled or qualified to enroll in Kentucky Medicaid. They must have a primary diagnosis of a serious mental illness, which is defined in statute in Kentucky, but includes things like schizophrenia, bipolar disorder, and they may or may not have a co-occurring disorder to go along with that. But it has to be that primary diagnosis for the lead. And then they need to demonstrate evidence of functional impairment and have needs that can be met by those services that we have. The functional needs can be societal, interpersonal, cognitive, or intellectual, something that just indicates that the individual has some needs that we can address through the offered services. Slide. The services that are going to be offered are here. There's 10 of them, and I'm going to go with the last one first. Case management is the service that everyone who enters the program will receive. After a pre-screening and assessment process, the individual will be able to choose their own case manager from a list of approved providers, and then that case manager will collaboratively work with the individual to develop a person-centered services plan that involves utilizing one of those other 9 services. An individual may receive any kind of assistance from supportive technology, some kind of app for their phone to help them remember medications, all the way on up to supervised residential care. Some of those may be mixed, but they can't duplicate one another. And case managers need to be conflict-free, so they will not be providing any of those other services. Slide. The RISE providers, we are getting ready for phase 1 of the go live for this program, and starting 7/1, we will be able to accept inquiries and applications for certification from providers across Kentucky. We've tried to streamline the process to make it as efficient and effective for folks in the field as well as folks in Frankfurt to speed that process. We will be offering training to staff, and there's a baseline training required of all staff that will have direct contact with individuals, plus ongoing assistance to the providers that seek certification so that we can help you succeed, which will then in turn help us and our participants succeed. It is fee-for-service Medicaid payments for 10 services. I think I saw a blip go by of the fee schedule. We're getting ready to publish that to our website, and I believe it'll be going up on Medicaid's website here in the next day or two. There's no managed care contracting. It'll be direct billing between the provider and Kentucky Medicaid, and it'll be part of a transformational statewide initiative that we are all very excited about. Slide. Excuse me. Let's see, the providers, we're beginning to do outreach. Keep an eye out for things that are going to be, you'll see some social media posts. We plan to have a community town hall sort of meeting kind of mid-July. But if you would like to reach out to us, we would love to chat with you. You can go to our provider email address, which is there in the first bullet, 1959 RISE provider at ky.gov. You can, if you know a participant or potential participant or advocates or someone who might have an interest, but they aren't interested in being providers, the second email address, 1959 RISE initiative at ky.gov, is a more general inbox. And we now have our website up. Then on our Department for Behavioral Health, it's a sub-page. You can drill down to that. We've got further pages for specifically targeted to providers and to participants or potential participants, as well as some supporting documentation. For the next couple days, be kind to the website. We're still adding and tweaking that a little bit as we go along. But like I said, we would love to hear you. The email box, both of the email boxes, you'll get an automatic response to if you send something into those. But I'm the one who monitors both of those email boxes, so I'll get right back with you pretty quickly. The second phase of our Go Live will be bringing on the participants. They will, once we have the providers on, and have them trained and ready to go, there'll be a list of them will be available to anyone on the department's provider directory that's also on our webpage. And then come about the end of August, 1st of September, we'll begin reaching out to potential participants for them to go through a pre-screening and assessment process. And once they complete that, then they can be assigned to a case manager. Slide. And if you have any questions that we can answer, that we would be happy to chat with you and see what we can get information to you as quickly as possible. Ann Holland is the initiative lead, and her email contact information is there. And you can reach me at tanya.dickinson@ky.gov. So glad to have had this opportunity to chat with you and look forward to working with you closely in the future. Thank you.
Well, it looks like I'm up. Hi, everybody. I'm Donna Jones. I am the nurse administrator for the Traumatic Brain Injury Trust Fund. And our program is housed in the sister agency in Dale. So it is, like I said, it's a great pleasure to be here and talk with you guys a little bit about our program today. Next slide, please. And the next slide, please. All right, to just jump right in there, there is a statute definition of a traumatic brain injury. A traumatic brain injury, as defined in statute KRS 211.470, it means a partial or total disability caused by injury to the central nervous system from physical trauma as well as damage to the central nervous system from anoxia, hypoxic episodes, allergic conditions, toxic substances, or other acute medical clinical incidents resulting in impaired cognitive abilities or impaired physical functioning. So, an important point I want to make about that definition with regard to our program is that it is not just trauma specific for us. We also consider for eligibility any of those other circumstances, anoxia, hypoxia. So we're talking about near drownings, strokes, all those things are also definitions of brain injury that we consider for eligibility in this program. Next slide, please. So, housed in the traumatic brain injury program are actually two programs. The main program that we have, and the one that I'll probably talk the most about today, is the TBI Trust Fund program. But it is important for me to mention that we also have a TBI behavioral program. Now, that program is very small. We only have the capacity to serve 8 to 10 individuals at a time. So, that one I probably won't dwell on quite as much. With the TBI Trust Fund program, however, at any given time, we are serving somewhere between 500 and 800 Kentuckians at a time. So the TBI Trust Fund was created in 1998. It provides non-medical services to children and adults with brain injuries across the state of Kentucky. By regulation, we are considered the payer of last resort in this program. So we serve in the TBI Trust Fund, it's cradle to grave. Okay. With regard to the behavioral program, that program also functions to assist in providing behavioral supports and interventions. Once again, it's all non-medical to individuals in order to ensure their ability to maintain safe living in the community. So within the TBI behavioral program, we're actually talking about individuals with brain injuries who are in some kind of a behavioral crisis. There again, in the behavioral program, we are considered a funding source of last resort. Next slide, please. Within the TBI Trust Fund, we are governed by a 9-member board of directors. We are housed in the Department for Aging and Independent Living, the Brain Injury Services branch. We distribute funds for services to individuals who qualify. We also contract with KIPRIC through UK. They establish and maintain our statistics and trends about traumatic brain injuries and spinal cord injuries all across the state. That research is quite valuable to any number of individuals and groups within state government as well as statewide. Within the behavioral program, the review team that we have determines an applicant's eligibility for services, identifies the needs that they have for crisis intervention and residential services, identifies the resources that they need for services, determines whether our program is actually the payer of last resort or not, and approves or denies requests for program services. Next slide, please. In the TBI Trust Fund, the source of our funding is actually really interesting. We receive 5.5% of the court costs collected by circuit clerks statewide, and 8% of the service fees assigned to DUIs. So our funding is limited, and our funds are what are considered restricted. So that means we do not receive any state general funds to support this program. We also receive no federal funding to support this program. On the behavioral program side, the funding is similarly dictated. It's 8% of DUI service fees. Again, the funds are set aside, meaning no general funds from the state, no federal funding. Next slide, please. Okay, let's focus a little now on the TBI Trust Fund in particular. Within the TBI Trust Fund, we provide what I would say is probably the most important service within this program is the case management component. We have 9 case managers scattered across the state of Kentucky, each of whom manages a pretty substantial caseload of individuals with traumatic brain injuries. We provide resourcing to assist people in accessing residential services if it's appropriate. And by that, typically that means helping them to apply for waivers that would address that need. We are typically asked to assist with funding things that nothing else pays for. So we try to fill those voids that typically waivers do not cover, or private health insurance for that matter. One of the big things that we are frequently asked to assist with is home modifications. Typically, there's not much else out there that can help someone make those home modifications to make their home accessible so that their loved one with a brain injury can continue to live in that home. We do a lot of bathroom modifications for roll-in showers. We do a lot of wheelchair ramps, that kind of thing. We also assist in funding for companion services and respite so that those natural support caregivers in the home can get a break, so that the brain injury survivors have a companion that can accompany them on outings, or to assist them in working on some of those social skills or money management skills, the things that sometimes they lose as a result of that brain injury. We also can assist in funding for some homemaking and personal care. We make frequent referrals for supported employment through vocational rehab. We can assist as payer of last resort for some structured day or some speech or OT. We do require in those situations that whatever insurance carrier an individual has, that those benefits are exhausted before they would be able to access us to continue to help them continue, with their OT or speech. Within the TBI Trust Fund, we cannot and will not pay for any medications. We can't do legal or attorney fees. We will not cover any costs related to hospitalization, any institutionalization, any home maintenance. So anything that would be considered the basic responsibilities of home ownership to keep a home maintained would not be things that an individual could apply to our program for assistance for, like, a new water heater or repair to their roof. Things like that are considered just part of home maintenance, and we can't assist with that. Next slide, please. This graph can show you our revenues and services. So if you look at it, you'll see that pretty much everything that comes in goes right back out. The little jump that you see in 22 and 23 is reflective of some of the federal COVID money that we were able to access. That funding that we were able to shore up our coffers with for a little while has been used. It's exhausted now. And so we are 100% back to that 5.5% of circuit clerk fees and DUI costs. Next slide. To be eligible for the TBI Trust Fund, it's pretty simple. An individual must be a legal resident of the state of Kentucky. It's open to all ages, cradle to grave. We do not look at income level for eligibility into our program. We do talk with individuals about income levels as we try to assist them in referrals and applications to other state programs, particularly different waivers. We do require medical documentation of the individual's brain injury, and they must be residing within the community. They cannot be housed in any kind of a facility, whether it's a nursing home, any institutionalization, even hospitalization. So they have to be out of any institution setting at all before we can assist them. Individuals who would not be eligible for our services are those individuals that are being treated and living in nursing facilities of any kind, individuals with spinal cord injuries where there is not also a brain injury documented. Those individuals we are not able to serve. We do not serve individuals with any form of progressive dementia, whose primary diagnosis is any kind of a psychiatric disorder. Individuals with birth defects, congenital defects, intellectual disabilities. We do not serve those individuals. Our services are not broad enough to offer the array and depth of services oftentimes those individuals need. So we try to assist and refer them on to access more robust programs. We do not serve individuals who have neurological conditions that are degenerative or progressive, such as ALS or MS. Next slide, please. So the application process to access to apply for the TBI Trust Fund is really simple. We will accept a referral. We joke in-house and say we will take a referral if somebody throws it on a rock through our window. We will take them by telephone at the phone numbers there, in writing via snail mail. And actually, we occasionally do get those still. We accept referrals by fax, by email. There's a link on our website there below. We also do not have any kind of specific requirement about who can make a referral to our program for someone. We get referrals from brain injury survivors themselves, as well as from family members, neighbors, friends, and any kind of provider. So we'll take any referral that we get and dig down in a little bit deeper and explain what's needed and go from there. Next slide, please. This is our referral link to do a direct referral online. We love to get those. But like I said, we'll take it if it's written on a rock thrown through our window. Once we get that referral, we do require medical documentation, and we look for some very specific documentation. Needs to be typically hospital records. If an individual has had a brain injury of any kind that is significant enough to have left them with residual deficit, they have typically been treated at a hospital. So we would like to see those records. We like to see basically somewhere between 10 or 15 pages of records. If in the perfect world we get what I'm really looking for, which is the discharge summary, the history and physical, the HMP of that admission, or the discharge summary from that admission, imaging reports. So typically there's a CT scan or an MRI that was done in order to determine the brain injury. So the imaging reports are helpful to us. We will not accept neuropsych evals or psychological evaluations from psychiatric providers as records for eligibility determination. Those records, however, can be helpful to us once an individual is in our program, because it gives us additional insight into what services they might need. Next slide, please. If an individual is determined ineligible for our program, they will receive written notice from us explaining, the statute and the reason that we found them to be not eligible. They are always given an opportunity to provide additional medical records, medical documentation for reconsideration. If an individual, however, is deemed eligible for services, they will be contacted within 3 business days by a case manager. The case manager will set up a time and opportunity to conduct an assessment, identify any needed services that they have, and set up a plan of care. Identify and refer to any community supports, natural supports, any state programs that they might benefit from. Once all of those needs are identified in any supports or services that can be accessed have been done so, anything that's left that cannot be addressed any other way, should it fall under our criteria that we can assist with, our case managers create a service plan. That plan is an application that they write up that explains what the individual's problems are, what their deficits are, what their needs are, and then makes the request. So, for instance, an individual may need a roll-in shower because they're wheelchair bound. So that case manager would write that application up. The survivor and their family member would be required to submit some paperwork demonstrating that the home is owned and not rented in that situation, as well as some quotes. Then that application and supportive documentation would go onto our waiting list. The waiting list is maintained chronologically. We have a review committee that meets quarterly and reviews the applications that come in for funds. The review committee will approve or deny those applications chronologically as they came in until our funds are exhausted for that quarter. Next slide. Okay, seems like time is up. So just real quickly, I hit a couple of points. Within the TBI Trust Fund, we have some caps. We have a $15,000 in a rolling calendar year, $60,000 lifetime benefit. At that time, an individual is no longer going to be able to receive services from us. People are in our program as long as they elect to do so, with the exception of a few situations like noncompliance, or if they are threatening to our case managers, or if they move away, go into nursing home care or something like that, or they just don't need any services from us for a while. Next slide. Okay, next slide. I think this is enough for us. If anyone is interested in more information about the TBI Trust Fund, we would love to talk with you. The slide previously that listed all the ways that you can make a referral, reach out. You can also reach out to us. Scott Collins is our branch manager. You can contact us at the 800 number or the 502 number. You can also ask us any questions at daletbi@ky.gov. Thank you guys so much. It's been a great pleasure today.
Hello, everybody. I just have a few slides to talk about our Healthy Kentucky Home. And this month we're talking about men's health. Next slide. Um, Similar to what we've talked about in the past, we really want to encourage people to eat 2 fruits and vegetables a day, exercise 30 minutes for 3 times a week, and then engage more with others. And doing all of these things can help you stay healthier. So next slide. When we look at men's and women's life expectancy, we have different ways to look at it. If you look at it at birth, so babies born today, men will be male babies can look forward to 74.8 years of life and female babies to 80.2 years of life. So that's more than 6 years longer if you're born female. Now let's look speed forward. If you're 65 years old and a man, you can look forward to 17 more years of life, and women 20 more years. So there is a difference between men and women when it comes to life expectancy. So guys, you've got to, eat your vegetables, exercise, and engage. So next slide. The top causes of death for men are number 1, heart disease, number 2, cancer, and then number 3 is unintentional injuries. And that one is not up there for women. Unintentional injuries is the 3rd leading cause of death for men. They are about twice as likely as a woman to die from an unintentional injury. And the most common causes are either overdose, motor vehicle accidents, falls, and then you can add different things in there, such as gun accidents. Next slide. And according to the Center for Disease Control and Prevention, when you look at the nation, almost 42% of men were obese, 12% smoked cigarettes, and 52% had high blood pressure, with 14.7% of men saying they were either in fair or poor health. And that's all men. So not over 65, that's starting at 18 years of age. So we've got to do better. Next slide. We also notice that compared to women, men are more likely to make unhealthy choices, including what they put on their plate. And so ice cream is a biggie. Different things like that. Men are much more likely to go after those unhealthy choices. And so good nutrition is critical for good health. And we've talked about this before. You are what you eat. So try and get at least 2 fruits and vegetables a day. I don't know if I would advise broccoli ice cream, but you can consider it. Next slide. Eating together as a family is a great way to engage, but it also encourages healthier eating habits. It promotes bonding with the family. You get to talk about your day, talk about homework, talk about work, or just avoid those things and have a fun family time. It helps in social and emotional development, and kids of families that eat together tend to eat less fast foods and eat more fruits and vegetables. So it's important for the whole family, not just the dad. Next slide. Another important thing is seeing your doctor regularly. And a lot of times men don't make time for regular checkups. And we see this in our data that women are going to the doctor more. They're getting their preventative screenings more. And think about it. High blood pressure is a leading cause of heart disease for men. And it's easy to control with medicine, but you don't know you have it unless you go to the doctor. So it's important to get those regular checkups. Next slide. Another thing they do at your doctor's, starting at 45, is they screen for prostate cancer. And prostate cancer, former President Biden was just diagnosed with metastatic prostate cancer. It can happen at any age, and the longer you live, the more you have a 1 in 8 chance of being diagnosed with prostate cancer if you're a man. In 2025, in the United States, we'll have over 300,000 new cases of prostate cancer with 35,000 deaths from prostate cancer. That is huge. And all you have to do is screen, go to your doctor, get screened. Screening is a simple blood test. I wish a mammogram, a blood test for breast cancer was as simple, but instead we have to get a mammogram. So just a simple blood test. You don't have to get any invasive screens, just the blood test. So please get that done. Next slide. exercising 30 minutes a day, 3 times a week. It's important for all ages and stages and physical abilities. It helps you not only get your heart rate up, move your muscles, but you can do it with a buddy, with an exercise buddy, and engage at the same time. It'll be more fun and less of a chore and more of a social outing. So it's very important 3 times a week to get this done if you're a man. Next slide. We talked about social engagement. It can take many forms. You can gather with friends, you can volunteer, you can join clubs like a chess club, like the guys on the slide, or a beekeeping club, if that's what you're into. It helps buffer against stress and anxiety. It builds resilience. It's also shown that people with social connections have less depression, and it just helps you form bonds that will last a lifetime. So next slide. Last slide here, summing it all up. Eat healthy, 2 fruits and vegetables a day, exercise 30 minutes a day for 3 days a week, and engaging with others. That's all you have to do. Thank you.
Thank you, Dr. Terrio. You do such a great job of condensing that information. And I know I appreciate it. And I do wish there was a blood test for all cancers. So this is just thank you for those who've hung with us. Just a reminder that if there is a particular subject that you would like us to provide an update on or cover, we're always open to those suggestions. So you can put them in the chat or get those to us. Next slide, please. And that I think will wrap us up. And again, I appreciate everyone being with us today, and we'll see you next month. Thanks.